So today I'm going to discuss on routine lab markers in COVID-19 pandemic, myths and facts. So this I already acknowledge all the diagnosticians present here. I am really thankful that you all are attending the session, and the role of lab physician, I want to acknowledge your role of lab physicians, role of lab diagnosticians from all the aspects of our life. Our role has redefined during this pandemic, and for us diagnosticians, every blood sample tells us a story. Let's see how. So this I already shared. So these are few of our papers recently published, and these are few of our news articles in different newspapers and journals. So I'll start with this case study. This is one 67-year-old known case of diabetes, hypertension, CKD on maintenance, hemodialysis, COVID-19 positive, SARS-CoV-2 by our RT-PCR was positive. On routine evaluation, he came for dialysis and it was positive. No history of contact, no history of travel, very high-grade fever with breathing difficulty, chest X-ray showed bilateral infiltrates, ground glass opacities on chest, HRCT. And if you see the markers, now what? Patient came for routine lab evaluation, and then our RT-PCR was positive. And what next with breathing difficulty and fever and SARS-CoV-2 positive? So these are the different battery of tests if you see. And voice is fine. No, I can see many participants are raising hand. I think my voice is fine.
Yes, ma'am, we can hear you.
So these are the battery of tests. If you see, CRP is one of the most important marker we realized during this COVID-19 pandemic. And here in this case, CRP raised around 17. And if you see transaminitis, ALT, AST is another important marker. Then liver function test derange, and then creatinine increased, and because of kidney injury. And if you ferritin is more than 40,000 in this patient, and D-dimer is raised, and blood gas derange. If you come neutrophil lymphocyte ratio, NLR ratio is deranged. So neutrophil is raised and lymphocyte is decreased, so NLR ratio derange. And here there is a cardiac injury, HS troponin I is raised. And coming to procalcitonin is a marker, and for seeing like if there is a secondary bacterial infection is there or not. Usually we see in COVID-19 procalcitonin is low or normal, but if there is secondary superadded bacterial infection, we see PCT high. So these are different marker or different battery of tests from which we come to know, this is kind of critical or severe COVID patient, and here the cytokine storm is raging. So based on the routine lab markers, if you see based on routine lab markers, the clinicians then decide what therapeutic monitoring or what therapy should be given, and we can classify based on mild, moderate, severe. So coming to all of us are battling against this second wave, and now there is a deep we are seeing. But again, we are very much concerned about our third wave. So coming to those different strains of second wave. So there are, according to CDC, Center of Disease Control and Prevention, CDC, there are 3 classification: variant of interest, variant of concern, and variant of high consequences. So VOI, VOC, and VOHC, there are 3 types of classification defined by CDC. So if I am describing according to CDC the nomenclature, but WHO again renamed that as Alpha and Delta, and also I will come to that later. So if we see the UK variant B117, this is a variant of concern, and experts suggest that this variant was 70% more infections than the other variants and raises the death risk to 60%. Now coming to Brazil variant, that is P1, is believed to be more contagious and dangerous because it has E484K, an escape mutation which dodge the antibodies or evade the antibodies. And the South African variant is B1351. It was found at least 20 countries, including UK, and the Brazil variant has E484K mutation, and again it does immune escape and it dodge antibodies, and additionally it has N501 mutation which make it more contagious. Now coming to Indian origin, because you must be reading different newspapers about the Delta plus strains. So second wave mainly caused by Indian origin double mutant virus, scientifically termed as B1617. And it was identified around March end in the state of Maharashtra and continues to drive Indian second wave of coronavirus. Now we are seeing the dip, but it was the many people was giving that maybe one reason where we saw the sudden surge of the second wave. And it contains E484Q and L452R mutations. So we were very happy, during January, February 2021. So there was dip of the cases, very less cases that time. But suddenly during the March end, we saw the surge, and there were so many, many of our even relatives or close contacts, we were coming positive and all. So this were identified in Maharashtra, and then it spread at different parts of the country. Now the triple mutation COVID variant identified in West Bengal, Delhi, and Maharashtra. So the rapid surge or this crisis which India has faced recently, that due to double mutation crisis in India, and triple mutation is deletion of H146 and Y145, and mutation in E484K and D614G in the spike protein. So the triple mutant virus, the second lineage of the SARS-CoV-2 virus, to be identified in India, and it is called as B1618. So what are the reasons why these are more contagious? Because we saw during the second wave, one person in the family infected, the whole family got infected. So it was not the case in the first wave, but second wave we saw it was more contagious, and so the cause for that is enhanced binding affinity of those strains to ACE2 receptor. This may be having a possible role in increased transmission, and also it make it more contagious, and there are immune escape. So these are the different variants of concern and different variants of interest. By WHO recently renamed that. And if we see, like, alpha is B117, this is in UK variant. Then beta is South African variant B1351, gamma is P1 Brazil variant, and delta is B1617. 0.2, that is Indian origin voice variants of concern, and these others are the variants of interest. So now coming to recently, last 2-3 days, we are reading about Delta plus. So Delta variants of COVID-19 mutates in the Delta plus is highly transmissible Delta variants of SARS-CoV-2, and this is Delta plus or AY. One variant, and there is also, scientists are saying there is not immediate cause of concern because the incidence of these Delta plus variants are still low, and the variant characterized by acquisition of K417N mutation, and according to that, the scientists, the mutation in the spike protein of SARS-CoV-2, and because of that, the virus evade antibodies and and immune escape phenomena is there. And there are 63 genomes by June 7. Delta plus variants have been identified in different parts of the world, from Canada to UK to Nepal, India, everywhere. And it makes 6% of all cases in US. And earliest consequence of this genome was found in Europe in late March this year. And they are saying there is resistance to monoclonal antibody cocktail, which we know the recommendation of the protocol of treatment. So there is a resistance to monoclonal antibody cocktail treatment by Delta plus. And in its latest reports on coronavirus variants, the health agency said Delta plus are present in 6 genomes from India as of June 7th. So these are like, we see different strains, but do you feel these are the main reason, different strains are the main reason for this surge? I don't think so, because we saw, like, during second wave, the younger generations are more getting infected. And this may be reason the social distancing and also the vaccination was not covered in the younger generation. So I think our only hope is vaccination and masking up and social distancing. So we need to be careful about all those COVID appropriate behavior. Now coming to different stages, first stage or stage 1 is viremia or early infection. Stage 2 is pulmonary phase, and stage 3 is hyperinflammatory phase or hyperinflammation phase. So stage 1 in early infection, we see mild constitutional symptoms, fever, dry cough, diarrhea, headache, and the clinical signs or lab markers, what we see, like lymphopenia, and then increased D-dimer or mild increase of LDH. Then there is acute phase of pneumonia, stage 2 or pulmonary phase. We see shortness of breath, hypoxia, and there we see abnormal chest X-ray, chest imaging, transaminitis, no normal procalcitonin. And the third phase is hyperinflammation phase, where we see acute respiratory distress syndrome, SARS or shock, or the multi-organ damage, like sometimes cardiac failure, sometimes kidney injury, liver injury. All those multi-organ damage we see in this stage 3 or hyperinflammation phase, where the cytokine storms are raging. So if we see there, we see the elevated inflammatory markers like CRP, LDH, D-dimer, ferritin. These are the most important marker in that phase. Also interleukin-6 sometimes, and then if there is cardiac injury suspected, then troponin, NT-proBNP or BNP. So these are different stage, and based on different stage, the different treatments options are given. And now coming to, in stage 1, early infections, patient may be having fever for 1 day or 2 days. So do you feel the battery of tests are really required at that stage? Not at all. So we should, during this COVID pandemic, we should use our test appropriately, judiciously. Right test for the right patients at the right time is very important. So I will share with you some of the cases from where we will come to know, why it is important. So as we all know, this actually nothing to discuss, like the major symptoms: fever, chills, cough, tiredness, muscle, body ache or pains, and sore throat. And like GI symptoms: nausea, vomiting, diarrhea, runny nose, congestions, skin manifestation, rash, headache, new loss of taste or smell, any kind of presentation we have seen during the second wave, sometimes only back pain, and then when our RT-PCR was positive. And sometimes deafness. So any kind of presentation we have seen during the second wave, and many people are asymptomatic. And other serious symptoms visible emergency warning signs are difficulty in breathing, shortness of breath, persistent chest pain or pressure in the chest, new confusion, inability to wake or stay awake, bluish mark on lips or face. And these are the chest finding where we see it leads to acute respiratory distress syndrome or multi-organ failure. And in this is 41-year-old female who had fever and SARS-CoV-2 positive. So you can see multifocal ground glass opacities without consolidations on chest X-ray. So the risk of severity and mortality has been observed much higher in older people. This was during the first wave, but second wave we saw, like, younger people are most affected. ICUs and critically we were hearing the news of cardiac injury, cardiac disease, or mortality was also high. Of second wave, actually majorly younger generation was affected. So now coming to the pathophysiology, why we are discussing how the virus, the pathophysiology of different biomarkers and different clinical symptoms, and also the why treatment, what modality of treatment, this, and also the vaccine drive. So this all depends on the structure. Like we have spike protein and then membrane, nucleocapsid, and envelope. In SARS-CoV-2, the spike proteins bind to angiotensin converting enzyme 2 as a receptor for cell entry. After the spike protein binds to the cell human cell receptor, the viral membrane fuses with the human cell membrane, allowing the genome of the virus to enter the human cells and begin the infection. So studies have shown that S protein plays most important role in viral attachments, fusion, and entry, and as a target for development of antibodies and also early inhibitors and vaccines. So ACE2 expressing cells are alveolar epithelial type 2 cells, lymphocytes, extrapulmonary tissues like heart, kidney, intestine, these are affected. So now coming to this pathophysiology, early infections, SARS-CoV-2 target cells such as nasal and bronchial epithelial cells and the pneumocytes through the viral structural spike protein that binds with the angiotensin converting enzyme 2 receptors. So the type 2 transmembrane serine protease TMPRSS2 present in the host cell promotes the viral uptake by cleaving the ACE2 and activating the SARS-CoV-2 S protein, which mediates coronavirus entry into the host cell. So ACE2 and TMPRSS2 are expressed in host target cells, particularly alveolar epithelial cells. So if you see, like here, there are T lymphocytes, monocytes, and neutrophil recruitment, and then cytokine release enhances the inflammatory response. And there are influx of monocytes and neutrophils, and then activation of the coagulation leads to microthrombi formations, pulmonary thrombus formation, hyaline membrane formations, and continued inflammatory results. Inflammatory response results in the alveolar interstitial thickening and increased vascular permeability and pulmonary edema. So, and also there are T lymphocyte apoptosis increased. So now coming to lab's role. Next is, we all know the diagnosis depends on our RT-PCR, and diagnosis, the lab's role is most important. But if you see the staging, the prognostications, the therapeutic monitoring, the role of the biochemistry, immunoassay, hematology lab are such a pathology lab's role is so important in staging, prognostication, and therapeutic monitoring. And last but not the least, the role of epidemiological surveillance or pseudo-surveillance by antibody testing. So that's also play a very important role for decision making. Now coming to this are different biomarkers or markers in routine labs like leukocytosis, neutrophilia, lymphopenia, and for prognostication purpose, increased LDH, transaminitis, increased ALT, AST, total bilirubin, creatinine, and D-dimer, then procalcitonin, to procalcitonin if there is secondary bacterial infection, and then increased value of CRP. CRP plays a very, very significant role. And interleukin 6, sometimes if it is available, then interleukin 6, but it should be used judiciously. It's not 1 or 2 days of fever. We need to do all the battery of tests. It's not actually not required to do any, maybe CRP and D-dimer is absolutely fine at the initial stage, and not required to do all the tests. So if this are our study, this is ours was critical ICU, and we saw this is more than 1,000 patient study, which got recently published, and we saw these are the percentage, like CRP is high around I think, yes, CRP are raised in 79% cases. So there are also mild cases also involved, and basically there are critical cases. So, and high sensitive troponin I 25%, PCT raised in 30% cases, and then ABGD range around 52 to 58% cases, ferritin raised around 56% cases, D-dimer around 80% cases. So these are our statistics. So this early stage, which markers maybe only CBC and CRP, and ferritin, LDH, D-dimers. So when there is an inflammatory response and we are suspecting that there are fever is more than like 3 to 5 days, and then to be done all the markers, and then if late stage when there is an organ damage, cardiac and liver enzymes, neutrophilia and neutrophil lymphocyte counts derange, anemia. So when we suspect organ damage, then we can do all the tests, battery of tests to see along with to see if there is any macrophage activation syndrome or cytokine storm. And then these are the reasons why we see the positive effect, like complete blood count, increased white blood cell, we see increased neutrophil, decreased lymphocyte, decreased platelet due to bacterial superinfection, or decreased immunological response of the to the virus consumption, coagulopathy, and we see LFT derange due to liver injury, and albumin decrease, and transaminitis increase, ALT, AST, LDH increase due to pulmonary injury or widespread organ damage, and then troponin increase, NT-proBNP increase due to cardiac injury, D-dimer raised due to activation of blood coagulation or disseminated coagulopathy, and then procalcitonin increase due to bacterial superinfection, CRP due to viremia or with viral infection, ferritin increase because this is pro-inflammatory markers in severe inflammation, and cytokines like interleukin 6 increase due to cytokine storm. So the difference between the COVID-19 associated macrophage activation syndrome or MAS and the classical MAS, in COVID-19 associated MAS or secondary HLH, we see that this is more confined to the lung parenchyma and immediately adjacent bronchial alveolar lymphoid tissue, and it's associated with ARDS development, and there are less without reporting the classical organomegaly pattern, which we see like lymphoid organ hyperplasia or hepatosplenomegaly or adenopathy we see in classical MAS organ pattern. This is not seen in COVID-19 related macrophage activation syndrome or secondary HLH. So this is the difference. And so in severe COVID-19 cases, we see severe widespread alveolar and interstitial inflammations extend to closely juxtaposed pulmonary vasculature, elevated D-dimer, then MAS-like intrapulmonary inflammation resulting in lung-centric pulmonary intravascular coagulopathy, PIC rather than DIC. And we see COVID-19 associated macrophage activation syndrome or secondary HLH, elevated CRP, hyperferritinemia, other features including coagulopathy, abnormal liver function, and cytokines are increased, and so deranged liver function with coagulopathy, hyperferritinemia, these are the common. And if you may be hearing, there are a lot of cases after post-COVID also, there are several symptoms sometimes. So these are the long-term effects of COVID we are seeing. And so coming to the different markers like I will describe it in case studies, and I will describe like how it is evolving, like, even our biomarkers along with the treatment protocol in COVID-19, this is evolving. Like every month we are seeing, like, the treatment protocol is different, and different drugs are coming into picture. So this is early 2020, early I think February 2020. So because I have taken this case to make you understand, or to give you the view, like what we used to do during the early 2020, the clinician, what they used to do. So this is a case of 56-year-old physician, history of fever and cold since 6 days, associated with cough with expectoration and severe body ache, decreased appetite, mild hypertensive, history of, he was physician in one of the hospital. So there was this severe history of suspected contact, and close family was affected. They started that time hydroxychloroquine, all the healthcare worker was taking. So they were taking, and he started hydroxychloroquine on his own on day 3. And day 6, he came to our hospital, our RT-PCR was positive. And if you see these markers like, ALT, AST raised, GGT raised, and several markers, LDH increased, ferritin, D-dimer increased, CPK increased, then blood gas deranged, CRP increased, IL-6 raised, then neutrophil lymphocyte ratio deranged, leukocytosis. So this is the common picture of where we can see from these patients all these markers. The cytokine storm, and cytokine storm is raging. So see the treatment. So initial treatment was paracetamol, ceftriaxone, hydroxychloroquine. February 2020, beginning of February, COVID pandemic in India. So persistent high fever with that also. So day 9, increasing CRP, ferritin, and lopinavir, ritonavir, single dose they started, then stopped due to high QTC. The fever was increasing, patient was desaturating, the chest X-ray showed bilateral infiltrate, cytokine storm is raging, high fever, increased D-dimer, ferritin, LDH, and interleukin-6, acute lung injury. So that time tocilizumab was came into the new protocol. It was used, people started using that, some of the centers. So February 2020, so they started tocilizumab 400 milligram repeat dose after 1 day, but fever was persistent, inflammatory markers increased, oxygen requirement. So they started methylprednisolone 30 milligram twice daily for 3 days. With that, fever decreased CRP, no oxygen requirement. Patient got discharged after this roller coaster ride of several days. And I thank my clinicians for this. This is the case from Dr. Tanu Singhal. So this is another case, case 2. Now you will judge in this case when all the markers were required, the previous case, this case, you tell me, is it required to do all the tests or not? So this is like 43-year-old, no comorbidities, mild fever, cough for 2 days, test positive for COVID-19 on day 2, normal oxygenation, no hypoxia. So by seeing WhatsApp or some getting some prescription from somewhere else. So the patient did all the tests like CBC, CRP, procalcitonin, D-dimer, interleukin-6, HRCT, so all the tests. So 2 days of mild fever and cough, actually no test is required. But and if they want to do CRP, and in this case CRP, D-dimer can be done. But all those battery of tests from IL-6 and others is not required at that time. Now coming to, we are hearing about third wave, and third wave, we are thinking that when there are they are saying that it will affect the pediatric population. So because of that, I'm sharing one pediatric case. I think timing is okay, or should I stop?
Ma'am, you can continue, no worries.
So this is a 14-year-old female, fever since 3 days, rash since 2 days, SARS-CoV-2 positive, no history of contact, no history of travel, Yeah, clinical features: fever, persistent oliguria, tachycardia, hypotension. Our RT-PCR was positive. In this child, even total immunoglobulin antibody testing was positive. So this is a case of pediatric multisystem inflammatory syndrome, or PIMS. So nowadays, second wave, we saw so many cases of PIMS. And so if you see the markers, the CRP, if you see from 8.8, it raised to 22, and then again decreasing. So blood gas deranged. So this, I am showing this case to show you the trend analysis, interleukin 6 and D-dimer. So so it was around 2000, and then it was showing increasing trends. And ferritin, this is the trend analysis. NLR ratio deranged. Then there was a cardiac injury. So HS-troponin I was raised, NT-proBNP was raised. So this is pediatric multisystem inflammatory syndrome, or MISC. So now, second wave, we saw a lot of cases of MIS, and PIMS. So this present, like, the condition is like Kawasaki-like disease, and PIMS can cause damage to the heart and also multi-organ damage. And Kawasaki tends to affect children under 5, but in PIMS, we see actually it affected the older children and teenagers. And then PIMS linked to COVID-19, because most of the children had SARS-CoV-2 positive by RT-PCR. Sometimes RT-PCR and antibody testing both are positive, and sometimes both are negative. So this are like, we saw a lot of cases of post-COVID multi-system inflammatory syndrome in adult and children. So post-COVID MIS are also very common. So now coming to cardiac features, when the previous SARS or MERS, so we have not seen much cardiac injury. We have actually, the cardiac markers were never deranged. But with this SARS-CoV-2 or COVID-19, there are myocardial injury, cardiac injury, and cardiac markers are raised, and cardiac manifestation etiology seems to be multifactorial, comprising direct viral myocardial damage, hypoxia, hypotension, enhanced inflammatory status, ACE2 receptor downregulation. So this are the, we are seeing tachyarrhythmias, bradyarrhythmias, drug-induced increased QT interval, sudden cardiac death, decompensated heart failure, acute coronary syndrome, myocarditis, hypertension, etc., the myocardial injury during this COVID. So now coming to my summary slide, what are the important markers and what we should do in mild cases, moderate cases, and severe cases? CRP, the most important, association with risk of progression, severity, and outcome, helps in monitoring therapy, decision for second-line therapy. Now, procalcitonin, you should use it judiciously. If you are suspecting bacterial superinfections, then do procalcitonin. Usually procalcitonin remains low to normal in the viral infection, but there are many cases we saw secondary bacterial infections. So if there is a severe case, so then do procalcitonin. Coming to interleukin 6, it rises early, and initially thought it was a guide to therapeutic monitoring for tocilizumab, but for now, for tocilizumab, IL-6, doing IL-6 is not required. So we should use IL-6 if we are suspecting cytokine storm and severe cases, and if it is available, we can do IL-6. But for 2 days or 3 days of fever, no need of doing all the tests. Then coming to ferritin, correlated with increased risk of progression, severity, and outcome. So others are LDH, D-dimer, CPK, all of us know. Now coming to rule of 6. Suppose I am in a resource poor setting, or like as I told, the right time for right patient and right test are very important. So this rule of 6, like CRP more than 60 milligram per liter, and ferritin and LDH more than 600 nanogram per ml associated with disease severity. So we need the smart biomarker, specific, sensitive, measurable, available, affordable, and it should give response, timely response. So these smart biomarkers are important. So I want to thank all of you for attending this, and all the clinicians who are working tirelessly. And we saw so many deaths amongst the medical fraternity. So I acknowledge all the healers. This is my painting. I want to dedicate all the clinicians. And if you see this extended hand, that is of the diagnostic diagnosticians. We are extending our hands to heal and to help the clinicians to heal. And in this, the whole gamut, of testing depends on the diagnosticians along from all the all the sections of the lab. And also, if you say the administration leadership play a very important role, and also IVD industry, because the resources, supplying the resources are very important. So I acknowledge all the people here present. Thank you.
Thank you, madam, for such a wonderful talk. There are some questions in the Q&A section and also in the chat box. So I have separated.
Okay, fine.
Yeah, I've separated the questions in the chat box. May I read it out to you from the chat box?
Okay.
So Dr. Rajni Davar, she's asked a question about antibody titers. So she says, I have a question regarding antibody titers and present guidelines for doing it and its application, especially with respect to vaccination in infected individuals and also after vaccination. So
yes, this is a controversial question, but I'll take this. What Dr. Rajni means, like the vaccine passport, many of the people are recommending, but if we consider the Indian scenario, so using antibody titer for vaccination or after infection, if we consider the Indian scenario, I will not, I'm not very favor of that. But yes, like we have done the study, microbiology by microbiology friend, and extensive study, and like we have seen in the healthcare workers and for this antibody titer. And so this we have seen mostly after vaccination, these are raised, and this can give as a serosurveillance. I will say this has a very, very major role, like, if government take that as a serosurveillance or antibody titer as a major role. But I will not recommend everyone, like I have taken vaccine and after that doing antibody just to check my antibody has developed or not. For India, I think that's not a very viable solution.
Thank you, ma'am. There's another question from Dr. Hilda. She says, during the course of disease, can we say the markers are really correlating with the severity? Because she has observed CRP shows a downward trend when patient is still bad and then raises up again after 2 days. Same with IL-6.
Yes, like if you, as you have mentioned, we have to, in that severe case, like here, the right time, right patients are very important. Severe case, I can't say only based on CRP, I will decide. For severe case, I have even recommended to CRP, ferritin, LDH, and even sometimes IL-6 and procalcitonin. So we need to see, like even my cases also, you will see suddenly one day CRP was I think the pediatric case I shown, the CRP from 8 it was increasing and then it became 18 and next day it was 22 or 24 something. But we have to see the clinical symptoms. We can't depend on that. These are the clinicians, all of our clinicians are saying many people are giving based on D-dimer giving the treatment. So these are based on CRP on D-dimer. We should not judge the patients with the clinical symptoms are very much important. So we have to take with the clinical symptoms, the battery of tests in that severe cases.
There's one more question from Dr. Madhuri Gupta. She says, what would be the clinical interpretation for huge rise of D-dimer after 1 month post-COVID with all normal parameters? Is it serious to be considered?
There are, I have heard from the cardiologists, there are for different opinions. So like some of the cardiologists where if D-dimer raised, so the treatment protocol modified according to that. And but only based on, we have seen a couple of cases where all the markers are normal, but only D-dimer raised, because they take little time, like, to all the markers to become normal. But of course, like, 2 months after the COVID, so because nowadays we should be very much aware about post-COVID MIS, because now we are seeing a lot of cases of post-COVID multi-system inflammatory syndrome, or MIS, which is very common, we saw during the second wave. So because of that, we can't ignore Dr. Madhuri. I know her very well, so we really can't ignore, like, the persistent raise of D-dimer. So there we need to be aware, and we need to check about post-COVID, MIS, or we should be careful. Although we say, like, single markers, and we should not chase numbers. Even for our patients, some of our relatives must be every day sending us the reports, and but we say that please don't chase numbers, chase your clinical symptoms. So but in this case, we saw, as second wave, we saw a lot of post-COVID MIS, but we should be careful too.
Thank you so much, ma'am. And there are many questions, but due to time constraint, we will have.
I'm really sorry, all those, because I recorded and then it took a lot of time.
No, it's fine, ma'am. It's fine. And my hearty apologies for the technical disruption. So thanks again. And really, it was a fantastic lecture, and all the questions that you have answered to all the delegates. But due to some time constraints, delegates, we will answer your questions later. I will copy down your questions and pass it on to ma'am, so that she, if time permits, she will be able to answer. And sincere apologies to all the delegates too. So we move ahead to our next session of our next speaker, and I call upon Mr. Dharampal Sharma, who is the Senior Product Manager, Mindray India, to introduce our next speaker to the delegate. Thank you.
Good afternoon, everyone. First of all, I would like to thank Dr. Barnali Das for such a wonderful and informative talk ma'am has given. And I think this has enlightened everybody, and all the participants might have, got the idea about different markers, clinical use of different markers in COVID scenario. So now I would like to welcome or introduce our second speaker, Dr. Tina Liu. Dr. Tina Liu is a PhD in molecular immunology, and she has a vast experience in R&D. She has worked with Mindray R&D for more than 7 years, and now she is a clinical academic manager for International IVD Marketing Department. So Dr. Tina Liu, over to you.
Yeah, thank you for your introduction. And actually, I have already done the recording. So please, Penny, just play the recording. Thank you.
Yes, Dr. Tina, we are about to.
Ladies and gentlemen, today I would like to share my presentation with the topic Mandarin Clear Solution Against COVID-19 with all of you here. I divide this topic into 2 parts, and the first part is the laboratory investigation for COVID-19, and the second one is what can Mandarin provide. Okay, let's start from the first part. Let's look at this the pandemic of the COVID-19 worldwide. And this picture is from the WHO official website, and until June the 5th, 2021, there are more than 175 million confirmed cases reported, and also around 4 million confirmed deaths. Some countries are still facing the second wave and the third wave. Although vaccines are being administered, the pandemic seems to be still far away from over. For the clinical course and the symptoms of COVID-19, actually the basic reproductive number R0 is around 2.2 to 2.95, and the incubation time could generally between within 3 to 7 days and up to 2 weeks as the longest time from the infection to symptom was around 20.5 days. Symptom is generally between 2 to 14 days after infection. The most common symptoms include fever, tiredness, and dry cough. And the infection is typically spread from one person to another via respiratory droplets produced through coughing or sneezing. And no effective antiviral treatment has been identified. Those infected by coronavirus should receive care until the symptoms relieve. So that means everyone can be infected by the virus. How can we overcome the pandemic as many countries are facing the second and third wave? At the beginning of the pandemic, we were worried about how to diagnose this new infectious disease. How and for what aims do doctors usually use different methods for the laboratory testing? And what are the clinical utility of the serology test for laboratory testing? And what is the real value of serology tests during the pandemic? And this is the estimated course of the molecular or serological biomarkers of COVID-19 patients. There are 2 effective ways for doctors to detect the infection. One is PCR, and the second is serology test. So at the very beginning of the infection, it is very hard to detect the virus directly. But around the time right before the symptom onset, it is a good time point to do the virus isolation from the respiratory tract. And the median shedding duration of the virus is about 20 days. Sometimes prolongs to 37 days. So doctors usually use nasopharyngeal swab PCR to detect the virus directly during the period. Although, besides, doctors always prefer to use antibodies to support PCR to confirm the disease when the patients show up in the hospital with related symptoms more than 7 days. IgM antibody goes up at the time point, and it can exist in blood for about 1 month. It can indicate the acute infection around 7 days to 10 days after symptom onset. IgG antibody increases, and it can exist for months or years. It can also indicate recent or past infection. As we all know that there are 4 common diagnostic tests for COVID-19, and there are molecular assays like nucleic acid test or PCR, and antibody detection, antigen detection, and virus isolation and culture. So among these 4 measures, PCR and the virus culture are the gold standards, but virus isolation and culture need high requirements for culture conditions. And it has low sensitivity and neat and long TAT. So it is usually used for research and not popular in hospitals and labs. And the advantages of antigen test is a short TAT and low cost. The advantages of antigen tests are short TAT and low cost. But it also has some disadvantages like high biosafety requirements, and there are also some difficulties of sampling which may lead to false negative. I would like to emphasize the molecular assays and antibody detection. And for PCR, it is also a gold standard for diagnosis, and it has high specificity and can detect early infection of this disease. But it also needs high requirements on the lab, requirements. And there are also some difficulties of sampling and which may lead to false negative. The last one is the antibody test, which I would like to introduce more in the following slides. It has some advantages like short TAT, low cost, lower biosafety requirement, and high sensitivity and specificity, but it cannot be used as COVID-19 confirmatory test. It can only support diagnosis. So is the function of viral test like PCR test equal to that of serology test? Actually, PCR is used as a confirmatory test for COVID-19 diagnosis, but in the guidance of laboratory testing from WHO, serology tests can only support diagnosis in cases where nucleic acid tests are negative and epidemiological evidence is strong. And serology tests can also be used for epidemiological assessment. That means it can be used for epidemiological investigation or surveillance. And which parameters can be used to monitor COVID-19 patients? For example, for the prognosis. We can see from this chart that disease progression of the COVID, and this progression can be divided into 3 stages. And the first stage is the early infection. And during this stage, we can see that patients are suffering from lymphocytopenia and thrombocytopenia, and PT, CRP, D-dimer, and LDH are increasing during this period. And after the early stage of the infection, patients are going into the second stage, pulmonary phase. During this period, biological or hematological markers like CRP, ALT, and AST are all increasing. The third stage is a hyperinflammation stage. Patients are suffering from cytokine storm. A lot of biomarkers are increasing. Here, let's pay more attention to 2 immunological markers, procalcitonin and ferritin. Procalcitonin, or PCT, is a popular biomarker for bacterial infections and sepsis. Sepsis can result from an infection everywhere in the body, such as lung, respiratory tract, or urinary tract. Bacterial infections are the most common cause of sepsis. PCT is a prohormone of calcitonin, or CT. In healthy people, the PCT level is very low as it is immediately processed into a CT. With bacterial infection, PCT is rapidly induced in almost every organ and released into the circulation. Following contact with the bacterial endotoxin, PCT becomes measurable in the serum. serum between 2 to 4 hours and peaks around 6 to 8 hours, increased PCT level will decline within 2 to 3 days if the patient is properly treated. For procalcitonin, with inhibition effects of the IIF and gamma, its level remains low in viral infections. Among laboratory parameters, PCT is a useful marker for diagnosis and guide antibiotic therapies. So PCT is the most ideal biomarker for distinguish bacterial and infection from other non-infectious causes of inflammation or viral inflammation. So PCT can help clinicians distinguish bacterial infections from viral infections. So here are some examples of PCT clinical scenarios for COVID-19 patients. The first one is the patients admitted are usually checked PCT to figure out if there is a bacterial infection or viral infection. So COVID-19 patients, for COVID-19 patients, PCT is usually without bacterial infection, PCT is usually less than the cutoff value. However, PCT is always checked for ICU COVID patients to monitor if there is a secondary infection, and bacterial infections sometimes occur due to impaired immune system of these severe patients in there. Let's look at the association between COVID-19 and ferritin. During the third stage of infection, hyperinflammation phase, and the patients are suffering from cytokine storm. And during that time, a lot of ferritin and hepcidin are released into the circulation. Then the serum iron quantity is increasing, and the patients are suffering from hyperferritinemia, which can stimulate the viral replication and trigger and enhance the biological signal transduction of molecules inside of the cells. Finally, cause organ damage. Monitoring ferritin quantity in the circulation can also help prognose the disease outcome of COVID patients. Ferritin quantities of COVID survivors always return to normal. As the pandemic gradually eases, more concerns followed. Do recovered COVID-19 patients have some protective immunity against the reinfection? And do antibodies confer reliable immunity? We now have some types of vaccines, although we don't have a specific medicine for COVID-19. How can we know if we already have protective antibodies after vaccination? Is there herd immunity built after mass vaccination among a population? As the real situation of the herd immunity after mass vaccination is becoming the hot spot, all these questions should be answered after the vaccination. To explain what are the neutralizing antibody and what are the differences between IgM and IgG and neutralizing antibody, first look at the schematic of the SARS-CoV-2 coronavirus particle on the left. SARS-CoV-2 is an RNA virus in the family coronavirus. It consists of a single-stranded RNA genome in the envelope. There are different viral proteins such as M protein and spike protein, which is the protein that binds the ACE2 of the host cell. cells and allows the virus particles to enter an infected cell. Antibodies, as shown on the right, are those proteins against the spike protein and other viral antigens on the surface of the virus particles. Well, antibodies are binding the spike protein, particularly when they are binding the receptor binding domain of spike protein. They will block the spike protein, which needs to interact with ACE2 and prevent the virus from entering the host cell. It is the antibodies binding receptor binding domain are critical components of the immune response, and it's got to be a major correlate of the protection induced by all the different vaccine candidates. For IgM, IgG, and manufactured by Mindray, they are targeting RBD on S protein and also the full length of N protein in order to enhance the sensitivity to achieve the aim of supporting diagnosis. The target epitopes of IgM, IgG are not totally the same as the neutralizing antibody. In humans, there are three types of antibodies or immunoglobulins targeting the COVID-19. So these three types of antibodies are IgM, IgG, and IgA. The SARS-CoV-2, S protein, spike protein, and the nucleocapsid protein, usually we call it N protein, are the primary viral antigens used in current available antibody assays, such as Mindray first generation COVID-19 product IgG, and is targeting, is against the SRBD area and N protein together. And just like I mentioned, the first generation is used for supporting diagnosis. So this is the principle where the design. For the second generation, and SRBD IgG only targeting the SRBD area, which can directly interact with the ACE2 that can block this area and prevent the virus from entering the cell. So this kind of antibody is neutralizing antibody. For Mindray second generation COVID product is to detect neutralizing antibody is called SRBD IgG. But why we use neutralizing immunoassays instead of gold standard like virus neutralization test? Usually we use plaque reduction neutralization test, PRNT, to detect the neutralizing antibody generated after infection or vaccination. Because for VNT, it requires handling live viruses in BSL-3 laboratories. And it is also time consuming. It needs to culture cells, which typically takes 4 or 5 days. Because of these shortcomings, immunoassays are suitable and necessary for vaccine evaluation, both in clinical trials and after vaccination. So what is the intended use for neutralizing antibody measurements? The neutralizing antibody can be tested to identify donors with high titer convalescent plasma for therapy of critical COVID patients according to the guidelines recommended by FDA. And the second intended use is to evaluate vaccine response or aid vaccine development. Until now, a lot of vaccine projects are undergoing clinical evaluations, but all these clinical verifications can only be carried out in limited area or a few of countries and cannot be cover different populations. Also, there are individual differences in immunity, so chemiluminescence immunoassay can quickly and accurately indicate the immune status of the population after vaccination and help the government judge the herd immunity of their countries. Let's say, what can Mandarin provide? For the COVID products, we have the first generation IgG-IC and the second generation SRBD IgG. And as we all know, the first generation can support diagnosis of COVID, and the second generation SRBD IgG can indicate the immune response induced by the nitrogen infection and vaccines. And for the sample type, the doctor can use serum or plasma, and it is easy to operate. The time to first result is around 30 minutes. Besides, we also provide different models of instruments, and the throughput can reach up to 480 tests per hour, depending on different models used. And all the instruments are fully automatic, which can minimize the infection risks. And we can provide different packages such as 50 tests per bottle or 100 tests per bottle, which can satisfy different requirements from our customers. Since the first generation product, the IgG, has already been released, we have done a lot of evaluations in global market, and until the end of 2020, we have collected more than 2,000 data from 19 hospitals and labs in 13 countries, 1,030 from positive samples confirmed by PCR, and 1,013 results from negative samples also confirmed by PCR. And the sensitivity and specificity are listed here. You can say that from the PCR confirmed cases, the sensitivity, the 14 days after symptom onset of IgG was around 94%, and for the specificity is around 96%. The performance is seem to be good. We also did some evaluations in different countries and got some evaluation reports from different customer sites. And also the sensitivity and specificity were good. And COVID product can satisfy different requirements of our customers. Our customers published some scientific papers, and all of them are listed here, show the good sensitivity and specificity of our Mindray IgG. And the papers showed Mindray IgG assay with chemiluminescence methodology had better traceability and more objectivity than rapid test. So clear test is highly recommended with testing on automated platforms, and especially for a large scale of sample testing. This slide shows the evaluation of SRBD IgG at our customer site in Southeast Asia. They evaluated sensitivity by using convalescent serum. Sensitivity by using convalescent serum We can say from the upper table and that the sensitivity 14 days post symptom onset is more than 98%, which is comparable to the competitors in the market. SRBD IgG shows the highest specificity, 100%, by testing more than 300 pre-pandemic samples. After that, we collected totally 1,047 samples, and all of the samples were vaccinated samples, and they were collected from 18 hospitals and labs, and all tested by SRBD IgG during the past 3 months. From the table, we can see that there were 372 females and 672 females and 326 males, and the positive rate for females was 97.4%, and for males was 91.3%, totally 95.3%. The female group has more positive cases than the male group. Had more positive cases than the male group. After statistical analysis by gender, there was a significance between these two groups. We can speculate, in other words, maybe after vaccination, female vaccine receivers can generate protective antibody easier than male receivers. Also, we use the WHO standard material to standardize our SRBD IgG, and the conversion factor is listed here. The Pearson correlation coefficient is close to 1, and the conversion factor is more than 0.8. These are the pictures of our evaluation sites all around the world. Almost all the evaluators were satisfied with our COVID assays. There are also some unknown questions left for COVID-19 and vaccines. And what is the dynamic changes of the neutralizing antibody? And how long do antibodies confer immunity? And from 1 on is a patient protected. So we don't know these up to now. And for COVID-19 related assays, here are our PCT performances. We are using one-step sandwich method, and the time to the first result is only 17 minutes, and it is suitable for stat samples. And actually, the sample volume is very low. It's only 25 microliter. And when compared with Roche PCT and ours correlates. When compared with Roche, Roche PCT and ours correlates very well, and the correlation coefficient was 0.98, and the slope was 0.99, and very close to 1. And even we compared in the low value range, the range between 0.1 to 0.5, and also the range between 0.5 to 2. And the correlation coefficients were also very good. Both were more than 0.9. Here is the performance of our ferritin. Actually, we compared our ferritin also with Roche in 2 different places. One is in Ankara Teaching Hospital, which is located in Turkey, and the other one is KingMed Diagnostics. Totally, we tested around more than 300 samples, and the correlation coefficient were very good, and both of them were more than 0.96. and the onboard stability of our ferritin is around 56 days. Okay, there are the take-home messages for my presentation. And for SARS-CoV-2 assays for IgG, it has good sensitivity and specificity and can be used as an aid to diagnosis, especially when PCR test is negative, but there is strong epidemiological evidence. Mandarin SARS-CoV-2 IgG assay is fully verified and validated. No adverse events occurred. Most of the evaluations were excellent. For SRBD IgG, identifying SRBD IgG is very important to know the immune response induced by nitrate infection and vaccines. Identifying SRBD IgG is also significant for vaccine receivers to know the real immune response before vaccinated. As recommended by WHO, recovered patients seems not to be reinfected within 6 to 8 months. It makes sense for the government to reasonably distribute limited vaccines to the population in priority, like healthcare workers. And for procalcitonin, PCT can help clinicians distinguish bacterial infection from viral infections. PCT is always checked for ICU COVID-19 patients to monitor if there is a secondary infection, because bacterial infections sometimes occur due to impaired immune system of these severe patients in there. So time to first result is short, only 17 minutes. It is suitable for start samples, low sample volume, suitable for pediatric samples or rerun samples. It has high sensitivity and good correlation with Roche. And for ferritin, monitoring ferritin quantity in the circulation can also help prognose the disease outcome of COVID patients. Ferritin quantity of COVID survivors always return to normal, and long onboard stability around 56 days, and also good correlation with Roche. Okay, thank you for your attention.
Thank you, Dr. Tina. So there are no questions in the chat box. So I think we move ahead to the next speaker of the day. And I invite Mr. Dharampal Sharma again to introduce our next speaker to the delegates. Thank you.
Thank you, Kshama. Thanks a lot, Dr. Tina. You have given a detailed know-how about all the parameters, what we have on Mindray solutions. So thanks a lot. Now I would like to introduce our third speaker, Dr. Tim Yin. Dr. Tim Yin is a medical laboratory scientist. He was attending physicians and medical laboratory scientist in Hawaii Hospital. So Dr. Tim will be giving his talk on biomedical analysis for better medical practice to COVID treatment. So Dr. Tim, over to you.
Good day, ladies and gentlemen. My name is Tim Yin. I work in Mindray as a clinical academic specialist for biochemistry product line. Well, it's a great honor to share this information about COVID-19 lab tests and our products. The topic Well, for today's sharing is biochemical analysis, better medical practice to COVID-19 treatment. Well, the contents are mainly containing a brief introduction of COVID-19 laboratory investigations, biochemical tests highly related to this pandemic, and COVID-19 related performance of our biochemical products. Okay, let's move on to the first section, laboratory investigations of COVID-19. Well, we know that COVID-19 is actually a viral infection, and the pathogen is SARS-CoV-2. Well, just like all the infectious diseases, there are specific tests to help doctors identify the specific infection. Well, in another word, to make the diagnosis. But for this one, COVID-19, the essential rule of clinical laboratories in this pandemic extends way beyond etiological diagnosis of SARS-CoV-2 infection. The diagnosis is a starter, and the following therapeutic management, the main course, are much more significant to some extent. Laboratory tests, which are not only target to SARS-CoV-2, to the virus, I call them ordinary tests, well, compared to specific tests, could do more. Well, for example, assess the patient's status. Well, the patient is a mild case or a severe, even critical case. To predict the patient's outcome in the beginning, and to monitor the patient's response to the treatment and help the doctors make further medical decisions. Okay, let's check the specific laboratory investigations. There are typically two kinds of specific investigations. Capture the structural components of the virus, for example, NAAT or PCR to test genome RNA of SARS-CoV-2, antigen test to identify proteins of the virus, protein S, M, or protein N. And also, there are methods to test the host immune response once an individual is infected by SARS-CoV-2. For example, the antibody tests, which target to SARS-CoV-2 specific antibodies, IgG, IgM, IgA, and so on. For a suspected COVID-19 patient, the major purpose of specific parameters is to help doctors make the diagnosis. Okay, let's move on to the ordinary laboratory investigations. The response of a human infected by SARS-CoV-2 is not only immune response, well, obviously. Cellular components could change significantly. For instance, we all know that lymphocytes decrease in COVID-19 patients, as well as platelets changes. It's a similar story to the products of human cells, no matter physiological products or pathological products. CRP, ferritin, D-dimer, LDH, electrolytes, cardiac troponin, cytokines, etc. Well, in my sharing, I'd like to focus on the top 4 parameters: CRP, ferritin, D-dimer, and LDH. Biochemical monitoring of COVID-19 patients through in vitro diagnostic testing is critical for assessing disease, the severity and progression, as well as monitoring therapeutic interventions. And we can see from this chart that Well, from the infection to the end of this entire disease process, no matter the patient's symptoms are mild or severe, and no matter the patient's in viral phase or in the host immune response phase, the 4 parameters are all clinically significant. Well, for example, we can see that ferritin D-dimer, LDH, ferritin D-dimer, LDH, CRP, and ferritin LDH D-dimer, and so on. Well, we can also see from this chart that for the relatively early stage of COVID-19, these 4 markers are quite useful because they change as the disease progression. They could be applied in assessment of patient status, monitoring of patient's therapeutic response, and predicting the patient's outcome in the beginning. Well, actually, these are exactly the clinical significance of all the ordinary parameters. Well, let's move on to CRP and ferritin. CRP, C-reactive protein, and ferritin are both known as acute phase protein. Such proteins have been shown to increase in response to stress. Well, for example, the viral infection. And both of them could increase in response to inflammation and cytokine storm. And we know that inflammation and cytokine storm are all related to COVID-19. Okay, let's see next parameter, D-dimer. D-dimer is a fibrin degradation product, a small protein fragment present in the blood after a blood clot is degraded. This net shown here is the cross-linked fibrin polymer, a unique structure in a blood clot. The small structure is D-dimers, well as shown in this picture, and it's so named because it contains 2 D fragments of the fibrin protein joined by a cross-link. Well, because of such features, if we could detect D-dimer in the blood circulation, we know that blood clots are formed in this patient. Well, thrombosis, to be more specific. For COVID-19 patients, especially for the severe or critical cases, increasing D-dimer is commonly seen. This parameter is a crucial marker for the management of these patients. For LDH, so far we have known that LDH is an enzyme involved in energy production, which means LDH could be found in almost all cells in the body. Tests that measure the concentration of LDH in the blood are commonly used to monitor tissue damage. Well, such kind of tissue damage are commonly associated with a wide range of diseases, and this makes LDH an important marker in COVID-19 management, because for COVID-19 patients, tissue damage, organ failure are also very common in severe cases. Cytokine storm and severe illness. I suppose we're already pretty familiar with this term, cytokine storm. It's an acute hyperinflammatory response that may be responsible for critical illness in many conditions, including viral infection, well, such as this one, SARS-CoV-2 infection. The phenomenon has been found in many COVID-19 patients. Critically ill COVID-19 patients experiencing cytokine storm, and these phenomena are believed to have a worse prognosis and increase the potential of this patient who could be die in the end. As for the 4 parameters, CRP and ferritin are related to cytokine storm by themselves. D-dimer is a marker of coagulopathy, and increased LDH in blood circulation means tissue damage and organ failure. They are really significant in COVID-19 management. Okay, biochemical tests. I'd like to show detailed information about the clinical significance of these parameters: CRP, ferritin, D-dimer, and LDH. For CRP in COVID-19, we can see that from the bar chart, the more severe the patient with COVID-19, the concentration of CRP is much higher. Critical group is higher than severe group. Severe group is higher than moderate group, and so on. And for a specific patient, CRP concentration increases as the disease is getting much worse. And also, for patients with COVID-19, we can find that if a patient is treated properly, the patient is respond well to the therapy, CRP concentration decreases. And for patients who are not well treated, like the control group, CRP remains in a relatively high level. For all severe cases of COVID-19 patients, the outcomes are either recovered or unfortunately dead. We can find from this study published on Lancet Rheumatology that patients who survived from COVID-19 have relatively lower CRP concentration compared to patients who couldn't survive in the end. As for the medical practitioners, when we are treating COVID-19 patients, we could know from the test results of CRP that those with constantly high CRP could have bad outcome, and those with decreased CRP concentration after treatment could getting better and with a greater chance of recovery. Okay, this is some findings and advice from some publications. For assessment and the prediction of prognosis, CRP for the COVID-19 patients, it could progressively increase as the disease progression. And also for CRP who are larger than 34 microgram per liter, plus age over 60 years, indicating high probability of mortality in 12 days. As for monitoring, it's advised that CRP should be orbitant at baseline and repeat as indicated. Ferritin, it's kind of similar to CRP as both of them are acute phase proteins. We can see that higher ferritin concentration means worse outcome. As reviewed by this chart, patients who died because of COVID-19 had a much higher serum ferritin concentration from the beginning of the illness to the very end. And for patients who recovered, the ferritin concentration remained in a relatively low concentration as shown here. And also, ferritin is a good parameter, a very good marker to monitoring the treatment. If a patient is respond well to the treatment, we can see from the charts, ferritin concentration decreases to a relatively low level. And this is some findings and advice from some publication about ferritin. For the assessment and prognostication as I've already introduced, ferritin is very useful. And because of this, it's suggested that ferritin should also test in the beginning to establish the baseline and then repeat as indicated. Okay, D-dimer. D-dimer is kind of the most important parameter of COVID-19 management. Higher D-dimer concentration in blood circulation means worse outcome. Well, as reviewed by this chart, patients who recovered from COVID-19 has a very low level of D-dimer concentration. We know that D-dimer is a marker of coagulopathy, the dysfunction of blood coagulation. But let's see the red line. It shows the dynamic changes of patients who die because of COVID-19. D-dimer increases, and even the patient is treated, the coagulopathy is still getting worse, and the D-dimer concentration is getting, well, much more higher as the patient is getting much worse. Additionally, we can find something else from this chart. We can see triangles is the D-dimer. And also, for patients who had severe COVID-19 in the end, the concentration of D-dimer is getting higher and higher as the illness deteriorates. But on the other hand, triangles are still the D-dimer concentrations. Once the patients are properly treated, for instance, using anticoagulation therapy, well, for this case, it's using low-weight molecule heparin. D-dimer concentration decreases and the patient recover in the end. Well, for D-dimer in COVID-19 management, assessment and prognostication, as I've already introduced, they are very significant. And as for monitoring, the suggestion is test in the beginning and repeat D-dimer test every day. Well, we know that anticoagulation therapy is quite important in severe and critical COVID-19 treatment. And that's why such patients are recommended to repeat D-dimer daily. Well, for LDH, higher LDH concentration means patients have relatively worse outcome, especially for these patients whose LDH are getting higher even they are admitted and treated in the hospital. As for patients recovered in the end, we can see that for one thing, the LDH concentration are lower than those who couldn't survive. For the other thing, their LDH has a decreasing trend like this one. Well, no matter for severe COVID-19 patients or non-severe patients, we can find from this chart that once these patients are well treated, LDH concentration decreases. Also, there are some findings and advice for LDH in COVID-19. Well, this parameter, LDH, is also suggested to test at baseline and repeat as indicated. Okay, let's move on to the last section, COVID-19 related performance. Well, I'm not a fan of listing all the figures and tables, so I choose two biochemical parameters, D-dimer and ferritin, as examples to highlight some features of our products. And these features happen to related to COVID-19. Well, to ensure laboratories can apply our biochemical parameters and ensure reliable test results. For D-dimer, for one thing, they are all fluid reagents, ready to use. And the onboard stability is 28 days. It's quite long, and this means less reagent waste, even for a laboratory with not that many samples to test every day. As for linear range, this is also quite remarkable for our biochemical D-dimer tests. When we compare the upper limit of us to calculation methods in FEU units, 96 microgram per microliter versus less than 20. Well, we can see that the difference is really significant. And as I've already mentioned, patients who couldn't survive from COVID-19, many test results are higher than 20. A method with a higher upper limit is much more cost efficient and well, can provide the results without without retests, and could report the results much earlier than other methods. The TAT time the turnaround time is quite short. Additionally, many COVID-19 patients are reported with hemolysis. Well, not that severe like these, but also, well, for hemolysis, it's pretty common in COVID-19 patients, especially for patients with severe COVID-19 illness. Well, and the Mindray biochemical D-dimer analysis has higher capacity of anti-hemolysis interference. All right, let's move on to ferritin. We can see that from this chart and this table. Mindray ferritin has a relatively high upper limit of linear range. This means, well, when using this test method, under many circumstances, well, they don't need to do the dilution, and there will be less rerun. And we did a survey in 4 top hospitals in China. The bar charts show the proportion of patients with ferritin concentration higher than the upper limit of the linear range when using different reagents. And we can see that, well, if the upper limit is higher enough, less samples require dilution and rerun. Well, for most of the ferritin tests, we are using immunological methods. Hook effects can occur when antigen concentration is higher than antibody and brings falsely low results. And we can see that Mindray ferritin reagents has higher hook point and a wider safety reportable range. Okay, let's do a brief summary. Well, we know that for these biochemical parameters, CRP and ferritin, they are related to cytokine storm, and this is relatively common in severe COVID-19 patients. As for D-dimer, it's a marker of coagulopathy, and this is also a common comorbidity of severe COVID-19 patients. Well, as for LDH and other ordinary parameters, they could reflect the existence of tissue damage of multiple organs, and this is also common in COVID-19. Well, as for the functions of biochemical parameters in COVID-19, they are mainly used to assess the severity of the disease, to predict the patient's outcome, and also to monitor patients' response to the treatment. Well, for all these parameters, especially these 4 I mentioned, Mindray biochemical reagents has a good performance to test COVID-19 samples. Okay, this is the entire sharing. Thank you for all your attention. Have a nice day. Thank you.
Thank you, Dr. Tim. And there are a few questions which I will read out to you from the attendees. There's a question, when is CRP ferritin levels expected in normal range post-recovery of COVID-19 infection?
Okay, thank you, Madam. Well, as far as I know, I didn't see much study about the CRP and ferritin levels after the patient is recovered from COVID-19. Well, for theoretically, we know that both CRP and ferritin are acute phase proteins, which means they respond really rapid to inflammation. And so theoretically, after the patient has recovered from COVID-19 and there will be no inflammation reaction at all in this patient, CRP and ferritin should decrease to the normal range, well, pretty rapidly. But also, well, we know that facing this globally pandemic, it's pretty difficult to do follow-up study in such patients, in patients who recovered from COVID-19. So I suppose I could only give you this answer from the theory, but because I couldn't find enough data to support this at this point. Thank you.
Can I add? Thanks, Dr. Tim. Very nice presentation. Like, you know, in our scenario, 2 weekly we do those for post-COVID follow-up. Like, and in this case, like, you know, 2 months. Some protocols suggest to do 2 weekly till 2 months.
Okay, thank you, Dr. Benali.
There are, Madam, you can stay. There are some few questions, if possible, is it okay for you, ma'am? Some 2-3 questions. Ma'am, you're mute.
Sure. Doctor, I'm there, Dr. Tim and
Okay. Thank you.
Dr. Tina is also there. I saw some questions.
Yeah, Dr. Tina is also there. Dr. Tina, can you come on video, please? Okay. So there's a question, at what interval the CRP, LDH, ferritin and D-dimer tests be repeated as diagnostic and prognostic testing COVID patients? At what interval the CRP, LDH, ferritin and D-dimer tests?
Well, in my opinion, I suppose it depends on
and prognostic testing COVID patients.
Well, in my opinion, I suppose for most of the patients who were suspected with COVID-19, they should test these ordinary parameters in the beginning to let the doctors know the patient's baseline. And then, well, with the process of diagnosis and other medical treatment, these parameters, the interval of these testing these parameters depends on the patient's status. For instance, for some severe cases who require anticoagulation therapy, D-dimer should be tested every day. But for a mild case, well, even some moderate case, maybe we retest these parameters every 2 days or every 3 days. It depends on the judgment of the doctors.
Absolutely, it's a judgment of the protocol, and actually hospital to hospital settings, as Dr. Tim mentioned, it depends on the clinical scenario, and like in mild cases, it's not required to repeat. Maybe one time the initial stage, but in moderate and when it is in severe moderate case also, like it depends on the clinical scenario, but in severe case, it may be repeated frequently based on the clinical situation. It's not like, daily or alternate day or something like that. Based on the clinical situation and hospital to hospital settings, and also based on the resource availability, it depends which test to be done and at what interval.
Madam, there's a question maybe that's specifically for you, maybe. Why third wave is considered to be more dangerous for children, and how many such waves are expected to come in the future?
It's very, very difficult. This based on our the scientists which they have said, because we have seen why third wave they are saying for children. The one of the reason is vaccination, because vaccination is as you may have seen, like elderly population was most affected in the first wave. I saw some question why second wave the younger population was affected. So vaccination that time was not done in the younger population, so they have just started. So because of that, that may be the one of the reason, the younger generation is more affected during the second wave, between the 30 to 50, because the elderly already had the vaccination at least one dose. So efficacy of the vaccine has because of that, whatever symptoms they had, that may be mild. I mean, younger generation also, the social distancing, and they are going for work and all. So because of that, we saw second wave is more common in the younger population. Because of this, may be the one reason, not the what we are saying, the strain, due to strain it is affected. This of course the strain may be affected in the younger population. That may be one reason, but the major reason is younger bread earning population. So because of that, they are going out, and younger generation affected. Now pediatric population, because vaccine has not started in the pediatric population, so they are not at all covered. So because of that reason, the most suspicion third wave, it will come to the it will affect more the pediatric population. And if you see that they are they are going out or something for playground and all, although the schools have not started. So we have seen during the second wave also the pediatric population is affected. And although they are sometimes asymptomatic, but with children we have very mild symptoms or asymptomatic, but when they come to home, and the whole the family is affected. So these children we are seeing mainly asymptomatic and mild symptomatic cases. But of course the PIMS, pediatric multisystem inflammatory syndrome, or post-COVID MIS, we are noticing in many now children actually is now becoming common. So the reason, I believe, the vaccination, because the pediatric population is still not covered. So that may be one of the strong reasons where we are expecting third wave will affect the pediatric population.
There is a question. Do you think 2 level of vaccinations are enough to develop right amount of antibody?
No, there are already there are efficacy between 70 to, most of the vaccine are giving around 70 to 84% efficacy, all of the most of the vaccines. But there are talk regarding booster dose and all. But currently what we have seen, with 2 doses of vaccination, whoever has taken, although they have got infected, but the symptoms are mild. Sometimes they don't require the hospitalization rate, statistics wise, are very less after 2 doses of vaccination. So the efficacy point of view, 2 doses in current situation is enough, but there is talk about the booster dose.
There is a question: how long do these antibodies stay in human body, and does a patient who is infected first get reinfected?
Usually we see 6 months, but based on this, the different studies. And yes, reinfection, although very rare we are seeing, but reinfection, we have seen many few cases of reinfection. So it's not that which we were saying previously during the first wave, the reinfection rate is very, very less. But we now we are seeing reinfections, but sometimes we see reinfections, mild or asymptomatic, where our RT-PCR is only positive. So it's not that reinfections are not there, but reinfections are less comparatively.
One last question, ma'am. This is Dr. Deepika Pandey, and she says, we are giving anticoagulants and steroids to COVID patients as management protocol. COVID can manifest as DIC. So is it necessary or not to monitor D-dimer status before starting anticoagulants drugs?
I think Dr. Tim, if he answers, I saw his slides very nicely. He explained. I think after him, I will
Okay. As I've already introduced, the baseline of these parameters, especially for D-dimer, is not only to monitor the response of this patient to the anticoagulants medication, but also in the beginning, the test of D-dimer could give the doctors some more evidence to see if this patient could going worse or this patient is mild as in the beginning. So, for this question, I suppose the D-dimer testing is still required in the beginning to see the baseline of the patient status and then repeat regularly. But once the patient is on anticoagulants therapy, D-dimer is required to test every day to monitor the changes of this patient's status. Thank you.
Dr. Tim, you are muted. Dr. Tim, you are muted.
Yes, I suppose I've already finished that answer. Thank you.
Okay. Ma'am, you need to would you like to add on something?
No, I saw his slides actually. Because of that, I have I thought let him explain, because it was a slide also. If you go back, it's very much nicely explained. But my one request is don't chase, because being a diagnosticians and being a lab physician, sometimes we are also sent all those values. So request your patient not to chase the markers, so and correlate with the clinical scenarios, and of course, as Dr. Tim has mentioned, when D-dimer should be used. But as previously I also mentioned, post-COVID MIS patients we are observing, so because of that sometimes those markers can be beneficial in those cases, not otherwise.
Okay, thank you, ma'am. Dr. Tina, would you like to add on something?
Yeah, I just noticed one question from the question box, and somebody is asking, after vaccination, antibodies start producing antibody. So, if is the antibody can lasting for the whole life? And actually, according to some published scientific literatures, the antibody can only last for about 6 months, not more than 1 year. So that is why after the vaccination and the vaccine receiver should be receive another booster after 6 or 12 months. So my answer is the antibody cannot last for the whole life. Yeah.
Okay, thank you so much. Now I would like to, there are a few more questions, but now due to time constraint, we are actually over time. I would like Mr. Sudeep Mukherjee, our Deputy Director, Mindray India, to convey the vote of thanks. Over to you, Sudeep Dada.
Thanks, Shama. Am I audible?
Thank you. Yeah.
Very
Yes.
good evening. Very, very good evening, ladies and gentlemen here. I would like to thank our all distinguished speakers here, Dr. Banali Das, Dr. Tina Liu, and Dr. Temian, for making an excellent presentation and making this CoviTalk webinar a very, very meaningful, interesting, and exciting for all of us. It was really a very thoughtful, provoking, and relevant topic, especially keeping in mind the pandemic situation in our country and its entire world. My special gratitude to Dr. Banali Das for finding out time for us from her busy schedule to bless this occasion through her immense knowledge and experience. She is a very well-known personality in the medical fraternity. Ma'am, we are privileged and obligated by your presence in this forum. Thank you. I'm sure the audience must have taken the best of learnings from this session and will use it to its maximum advantage. I must mention my deep sense of appreciation for Ms. Nina Zhang for her initiative to make this webinar a part of Mindray's continuous endeavor towards knowledge development program. Thanks, Nina. As no program can become successful with a single person, so I extend my big thanks to all the participants and the volunteers too. Thanks, everybody. Thanks all of you to making this event successful. We look forward to be working on many such programs in future too, and we'll be requesting your presence to help us making this successful for all of you. Your feedback and suggestions are welcome. Please share with us so that we can improve our programs in future. Thank you so much.
Thank you, Sudeep Dada, and thank you, eminent speakers, for making today's day such a popular day. Thank you so much.
Thank you. Thank you, Mindray.
Thank you. Thank you.
everybody.
Thank you so much. Thank you.
Thank you, everyone.
Thank you, everyone.